Hello, this is Chadi Alraies from Wayne State University Detroit Medical Center, and this is CVI 2018. With me is Dr. Perwaiz Meraj. He is the Director of Interventional Cardiology at Northwell Health. Welcome, Dr. Perwaiz. So today you presented at the panel Innovation in Interventional Cardiology, and you went over lesion modification and other technology. Can you touch off on the top three in 2018?
Sure. So in terms of lesion modification, the lesions that we're speaking about really are calcified coronary lesions, and those are the toughest lesions for us to really modify and treat. But we're seeing more and more of these patients. So really the innovation, the oldest innovation we've had in this field is, of course, as we know, rotobladers. Rotoblader actually, as Boston Scientific has developed a new rotoblader technology called RotoPro, as I'm sure everyone will start being able to see them. That's the newest innovation in terms of rotoblader technology. We, of course, have orbital atherectomy, which has been now around since 2014, which is relatively new in the area of in terms of atherectomy for calcified coronary lesions. And the newest kid on the block, which is really not an atherectomy device, but really a lesion plaque modification device, is Shockwave. And Shockwave is a very interesting technology which very few people really have gotten their hands on to really try and test. But it's going to become, I think, it's going to become something big. It's not going to be a replacement, in my opinion, for those other devices. I think they're all complementary devices, and they all have their role and they all have their place. But it's very interesting in an area where we're seeing more and more patients, as I'm sure you're seeing more and more patients that have very calcified complex coronary.
Right. So for going to the Shockwave and lithotripsy, it's like almost lithotripsy therapy. So is IVUS needed in order to modify the calcification, correct?
I think in the end, whether the word "needed" is the right word, I think it's not going to. I don't think anyone's going to write on a piece of paper that you absolutely need to use IVUS. But to be honest with you, with these calcified lesions, intracoronary imaging, whether it be IVUS or OCT, is hugely important for us to be able to determine whether we were successful in debulking the lesion and being able to treat the lesions properly. We probably have not had the outcomes we need to have with stent technology, probably because we haven't been imaging it enough.
And we're more and more seeing of this population coming to the cath lab because they're coming calcified and also with bad PAD. So you briefly touched in different session, probably not in this meeting, also about the alternative access. So what is your number one alternative access in the cath lab for a patient who has prohibitive PAD for large bore?
So large bore access is a very interesting conversation. So we, with your Boston colleague, Amir Kaki, has been one of the pioneers in this alternative access for large bore devices, and him with Jamie McCabe and Raj Sayal have really revolutionized axillary technique. And in my opinion, percutaneous axillary technique is absolutely the next go-to when you have prohibitive femoral artery access for large bore catheters, whether that be for structural heart disease, whether that be for large bore hemodynamic support. It's definitely going to be the wave of the future. It's not the simplest and the easiest technique. It requires a little bit of skill. However, if done right, it's very safe in the right hands. So we have to train people the right way to use it the right way. But I honestly, personally believe it's going to be the future.
I want to shift gear a little bit about training. Always ask you this question because you are relatively fresh graduate, but you have experience. I was told that during training you get a good exposure, but your first few years in practice really where you kind of sharpen your skills. Absolutely. Do you have same thing?
I completely agree. You will learn everything you possibly can learn during your years of fellowship, and it's invaluable. And what I would recommend to every fellow, and as times have changed, fellowships changed, but I would recommend every fellow get your hands on every single case you can possibly get your hands on. You will never experience that level of training ever again. But once you're done with your training, don't ever go out into the real world and expect to be able to do everything the first day you finish your fellowship, because that's unrealistic. Your first year especially, but again, you go to 2 years of being an attending, is really where you learn. You learn how to get yourself not in trouble. And I say that very carefully because it's easy to get ourselves in trouble in the world we live in. Our goal should be to prevent trouble, not to treat trouble. So we have to make sure that we do it right, because after all, you have to practice safe medicine for your patients. And if you go to a new institution, as we all know, no one knows you, no one knows who you are. And if you start taking on very high-risk, complicated cases and have complications, people won't trust you. So you need to make sure that you do right by your patients and you develop a reputation of safety, of success, and then you can take on even the more complicated lesions. But that first 2-year period of time is very important for you to learn. It happened for me, and I'm sure every interventionalist out there could say the same thing.
Right. So at the end, I would like to thank Dr. Meraj for your time. Always a pleasure talking to you on different platforms. Watch this video on the CVI Innovation website, also the YouTube channel, and also follow the hashtag CVI2018. Thank you.
Thank you.